Good morning. Welcome to the Center for Strategic and International Studies. I'm Sarah Allender, Deputy Director and Senior Fellow in the Global Health Policy Center. Thank you for joining us today for a conversation with Dr. Michael Merson and Dr. Merson and Inrig to discuss their new book, The AIDS Pandemic, Searching for a Global Response, which chronicles the early days of the global AIDS response, the establishment and eventual disbanding of the World Health Organization's Global Program on AIDS, which Dr. Merson led for several years, and the establishment of UNAIDS. We'll also discuss what lessons can and should be learned from those early days for how the world should react and respond to emerging public health crises. It's a testament to the efforts of the Global Program on AIDS and those who have come after that we now struggle to make the argument that HIV/AIDS remains a global public health threat that continues to need political will and investment through sustainable financing. It might help to pause for a moment and reflect on what was happening at the establishment of the Global AIDS Program in 1986. With no treatment available, fear, hysteria, confusion about how one could get infected permeated our discourse. The nightly news featured stories like those of Ryan White and the deaths of icons like Freddie Mercury. There were mass public education campaigns, television movies with cautionary tales of infection, and an AIDS quilt that toured the country. AIDS was everywhere. Meanwhile, a small but growing group of concerned medical professionals, researchers, and policymakers were struggling to build a global response. In the AIDS pandemic, Drs. Merson and Inrig provide a vital insight into the personal and professional efforts, commitment, and sacrifices that were made during that period. We owe a great deal of gratitude to those who dedicated themselves to building the knowledge, consensus, financing, and political attention to get AIDS on the global radar. One could argue that those early days were really the birth of global health as a field and a community of researchers, policymakers, practitioners, and affected populations working together against a common public health threat. Why is it so important to shine a light on those early days of AIDS now in 2017? We're here at a moment of opportunity with the HIV/AIDS pandemic, but it's an opportunity that is under threat. The concerted effort that started with the Global Program on AIDS at WHO and continued with UNAIDS, the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and the US President's Emergency Plan for AIDS Relief has gotten us to a place now that we only dreamed of being at 30 years ago. The possibility of achieving control of the pandemic without a vaccine or a cure. 7 countries have already achieved epidemic control, and 11 more are on the threshold. In July, UNAIDS released its annual report in which it reported that, for the first time ever, more than 50% of people living with HIV worldwide are on antiretroviral treatment. This is a tremendous accomplishment that comes after 15 years of concerted effort. Because treatment can lead to suppression of the virus, it's important because those with undetectable viral loads cannot pass the virus to others. Now, 30 years after the start of the Global Program on AIDS, HIV/AIDS is not seen as the emergency it once was. But that doesn't mean AIDS is no longer a public health crisis. In February 2017, we launched a working group on HIV here at CSIS with the goal of looking at the current issues in the global HIV response and making recommendations to the Trump administration and the Congress about the future of US investment. Our conclusion was that the global HIV response and the successes that have been gained are at risk. First, we've seen a waning of political level interest and funding for global HIV in recent years. Global HIV financing has decreased in the last 2 years, while US financing has been flatlined for 5 years. In President Trump's proposed budget for FY 2018, he proposed a $1.1 billion decrease for US global HIV funding. Second, significant issues must still be addressed and overcome. 47% of people living with HIV still need access to treatment. We need to find those who don't yet know their status and get them tested. And acute vulnerabilities put adolescent girls and young women at heightened risk in many countries, particularly in sub-Saharan Africa. 7,500 adolescent girls and young women are infected with HIV every week. And discrimination and legal prohibitions against other vulnerable populations, such as LGBTI, are hindering access to services in many countries around the world. Finally, adult infection rates have come down since the start of the pandemic, but they've plateaued at around 1.6 million per year. This is concerning because of the youth bulge in sub-Saharan Africa, which will see the numbers of adolescents and young adults double by 2030. 15 to 35-year-olds are less likely to understand their HIV risk and know their status than older adults, which means that if we're unable to break the transmission cycle and control the epidemic in countries with this youth bulge, we may see a reemergence of the epidemic at rates like those that we saw in the late 1990s and 2000s. Continued focused effort on global HIV/AIDS is a good policy strategy for the U.S. And our recommendations to the Trump administration and Congress in the Chapeau paper put up by the HIV Working Group, we advise that the U.S. government should sustain its investments to push towards epidemic control in those countries where it's possible in the next few years, while continuing efforts in countries that have much farther to go. We urge protecting the U.S. approach to fighting HIV through the whole-of-government PEPFAR program, investments to the Global Fund, and research into new advances like a vaccine and a cure. We also recommended focused investment in preventing new infections in adolescent girls and young women while reaching their 15 to 35-year-old male partners to stop the cycle of transmission. Making the argument that global HIV remains a fight that we need to continue to invest in is going to be key, which is why it's all the more critical now to understand how we got here, how the arguments used in the early days of fighting AIDS at the WHO and at the global level can inform our understanding of the current issues and help us figure out where to go from here. Let me now introduce our two speakers for today. First, Michael H. Merson is the Wolfgang Joklik Professor of Global Health and Vice President and Vice Provost for Global Affairs at Duke University. Dr. Merson joined the Duke faculty in November 2006 and was the founding director of the Duke Global Health Institute, serving in that role from 2006 to 2017. In addition, Dr. Merson served as Vice Chancellor for the Duke National University of Singapore Affairs from 2010 to 2016. Dr. Merson graduated from Amherst College and the State University of New York, Downstate Medical Center. After serving as a medical intern and resident at Johns Hopkins Hospital in Baltimore, he worked in the enteric diseases branch at the Centers for Disease Control in Atlanta, and then as chief epidemiologist at the Cholera Research Laboratory in Dhaka, Bangladesh. His research focused on the etiology and epidemiology of acute diarrheal diseases, including cholera, in developing countries and on the cause of travelers' diarrhea in persons visiting those countries. In 1978, he joined the World Health Organization as a medical officer in the Diarrheal Diseases Control Program. He served as director of that program from January 1980 until May 1990. In August 1987, he was also appointed as the director of the WHO Acute Respiratory Infections Control Program. In May 1990, he was appointed as the director of the WHO Global Program on AIDS. In April 1995, he joined Yale University School of Medicine as its first dean of public health and held that position until December 2004. From 1999 to 2006, he also served as director of the Center for Interdisciplinary Research on AIDS at Yale, which undertook research and training on HIV prevention in vulnerable and underserved populations around the world and in the US. Dr. Merson has authored more than 175 articles, primarily in the area of disease prevention. His most recent contributions concern HIV policy and prevention in developing countries and broader global health issues. He's also the senior editor of Global Health, Disease Program Systems and Policies, which is a leading global health textbook. Dr. Merson has received 2 commendation medals from the U.S. Public Health Service, the Arthur S. Fleming Award for Distinguished Government Service, the Surgeon General's Exemplary Service Medal, and 2 honorary degrees. He's also an elected member of the National Academy of Medicine. Dr. Stephen Inrig conducts research and teaches on the social determinants of health and the influence of health policies on vulnerable populations. He's a professionally trained health outcomes researcher and historian. Professor Inrig's peer-reviewed research has explored the role of local, state, federal, and global policy on people at risk for HIV, cancer, and mental illness. Dr. Inrig directs the graduate program in health policy and management at Mount St. Mary's University, and also serves as director of interdisciplinary healthcare research. Prior to coming to Los Angeles, Dr. Inrig served as assistant professor in the Department of Clinical Services, Division of Outcomes and Health Services Research, and was a member of the Harold C. Simmons Cancer Center, where he co-directed UT Southwestern's healthcare financing and policy rotation for the UT Southwestern School of Medicine, and taught health management ethics at the University of Texas at Dallas School of Management. Dr. Inrig's mixed methods research includes creating a health infrastructure analytical tool used to create an electronic medical record and navigational tool for breast cancer navigators in rural North Texas. He is also involved in an NCI-funded mixed methods project analyzing screening process, delivery systems, and EHR meaningful use applications across 7 health systems in the U.S., and is currently studying the effect of organizational and country-level cancer service capacity on breast, cervical, and colorectal cancer screening outcomes in rural and urban settings in 7 states. He has published retrospective policy analyses on the effect of state health policies on HIV screening, care, and control, as well as the effect international policy bodies have on national HIV epidemics around the world. He's served on the Institutional Review Board at the UT Southwestern Medical Center in Dallas, the Ethics Committee for Children's Medical Center, also in Dallas, and worked as program coordinator for the Promising Practices program at Duke. His research has appeared in multiple media venues. Professor Inrig received his PhD in the history of medicine and health policy from Duke University, his MS in clinical sciences from the University of Texas, Southwestern Medical School, and his MA in intellectual history from Trinity International University. Let us welcome Dr. Merson and Dr. Inrig.
We start?
Go ahead.
Well, thank you for hosting us. Thank you all for coming. Sarah had given us an outline of how we should introduce the book, which we're going to follow as best we can. Why did we write the book? How did we write the book? How did GPA, the Global Program on AIDS, how did WHO get started? What obstacles did it face when it got started? What was it like between the transition between the WHO program and shutting down and the beginning of UN AIDS? And what are the lessons, some lessons that can be learned? It's a lot to cover, so we're going to be probably pretty brief, but we hope you're all going to read the book, and it'll all make sense after you read the book. But we look forward to your input and questions after we present. So Sarah has explained why we wrote the book, and mostly, you all know about AIDS. I don't need to introduce AIDS and the struggle we've been up against since really 1981. And we just felt that we wanted to tell the story of how governments and agencies, for better or worse, have responded to the pandemic, starting with 1981. And so it's a 36-year history. It focuses, as Sarah's mentioned, to a large extent on the Global Program on AIDS of WHO, which we are going to refer to as GPA, which led the global response beginning in 1987. In some ways, WHO was involved earlier, really, with Fakhri Assad in 1986 and even in 1985. The Global Program on AIDS formally started, we can say, in 1987. Now, please remember, as we go through the book, there's no heart, there's no antiretrovirals. If you can, think about it. It's getting assumed that if you were infected, it was a fatal disease, and we had no idea where the pandemic was going. So some of you, if you can put yourself back to then I think that's the context in which we're telling this story. The WHO program was shut down in 1985, let's say after 8 years of operation, and we now know that was exactly the time of the peak of the pandemic. Retrospectively, we know that by looking at the data that we now have. It was closed down because of the performance of the program, displeasure with the unpopular Director General, and feuding between UN agencies. Now, as you heard, I directed the program from 90 to 95. I succeeded Jonathan Mann, who many of you died tragically in the Swissair accident in 1998. And he was recruited to that position by Fakhri Assad, who, I've already mentioned, deserves credit for starting WHO efforts. If I had to say one reason why I wanted to write the book, it was because no one had yet told the story about the 500 or so GPA staff who worked tirelessly and with incredible commitment at a time which one could argue was the most difficult period in the history of the pandemic. Now, in the book, we cover the time between 1981 and the beginning of the WHO program, when WHO's response, I'll be kind and say, was cautious, although we could also call it feeble, and the period following the closure of the program, when UNAIDS starts in 96 and faced incredible obstacles and challenges. And then the final section of the book brings the reader up to date on the global response. So in summary, the book uses GPA as a lens through which to trace this 36-year period of the changing response to the pandemic. And we very much focus on low and middle income countries in the book. For the most part, we have not covered the course and impact of the pandemic in the United States. That would have just been too much to cover in this book. And many other books do cover that, but almost no books that we're aware of have covered the 36-year response globally. So we know that that's a shortcoming of the book, but it was impossible to do both in one book. Steve, please add to that.
I think you've covered it really well. I think for me, I'm an interventional historian in the sense that I do both health outcomes research as well as historical analysis. And I think for both of us, we really wanted to craft a useful history, one that didn't just tell stories or try and set the record straight, but to focus on what can we learn from the story of HIV and global health institutions and how they were trying to organize against a pandemic that didn't necessarily come out of the blue, but caught many unprepared and really started to stress both societies and the health infrastructure in terms of how one responds to something of this magnitude. And Mike had obviously gathered, both from his personal experience and from his research, a wealth of primary source documents. So this kind of was a unique opportunity to capture this, but then to think about, are there things that we can look forward from this as lessons and maybe things to avoid as well as to implement.
And for me, it was great having a historian. Since I was in the middle of this period, and it helped me very much to have someone who was not as engaged. Although Steve was an expert on Strom Thurmond, I didn't think that should matter. And that this was part, for me, very helpful to have a historian write a history book, which of course I had no experience or understanding of how to write. And so he was a great partner for us. Now, how did we write the book? Well, in 2001, I reviewed the files, all the files of the Global Program on AIDS that were sitting in the basement of the M building of WHO. There's a whole story about that, which I won't go into here, how I got to do that. But anyway, I got to do that, so I reviewed all of my files. Steve and I also conducted over 125 interviews with key players in the pandemic, mostly in 2001 and 2002. We transcribed all of them. We also drew from approximately 1,300 source materials, maybe more, but those are the ones we reference in the book. The book is heavily, heavily referenced. And we also had the book reviewed by 5 external reviewers. We held the book up actually for 6 months to get those reviews from knowledgeable people, and if you look at the book, they're there, their comments are there, and they were very important to us in reviewing the book. And I see Jen Cates there, out there. You may not know, you may know Jen, but the Kaiser Foundation gave the only grant we got for the book, which was $25,000 to do some interviews. But we wrote the book, and I want to thank publicly the Kaiser Family Foundation, who probably forgot they ever funded us, for your contribution to the book, and that's the only support we received. We had 0 other conflict in writing this book, and we were in touch with Kaiser all the time during the period, so they knew what we were doing. Steve, please talk about all your hard work.
Well, I think one of the things that it impressed me when Mike came and approached me, I should say he had gathered an extensive amount of material before I ever got involved in the project, which you can thank his wife later because they've occupied. It's got to be somewhere between 7 to 10 feet of space in this closet of just boxes, which for a historian is wonderful because it's like your own archive, but you don't have to ask permission to go in there. And so we digitized all of that, which was thousands and thousands of pages. But the idea was to try and triangulate the story, recognizing that HIV and the story of AIDS and global international relations is very, very contentious. And Mike didn't want just to tell his view, but to try and place his story in the larger context. So we triangulated it, which meant that I went through all of his material and tried to get the story independent of the work that he had already done and transcribed his research. I used qualitative coding methods on all the interviews that he'd conducted, did several of my own. And then, of course, he's sending me things all the time about, hey, read this article and that kind of thing. And Jose and others pestered me as well. But what was good about it was recognizing that we weren't trying to tell, strictly speaking, the truth, but we were trying to tell the story from Mike's perspective, but to place it in the larger story so that most of you, and we used a lot of footnoting to make sure that you can do your own homework and follow where we came up with the conclusions that we got. So that rather than pretending it was objective, we tried to pretend it was fair. How could we tell the story of international institutions from Mike's perspective? We wanted to include the story of all sorts of other folks, Fakhri Assad, obviously, Jonathan Mann, and any number of you, many of you maybe even sitting in this room, institutions that don't get a lot of press or credit, but were on the front lines fighting for HIV long before it made the press or was uncontroversial or heroic to be part of that.
So that's how we got here. Now, what did we face in GPA on the Global Program on AIDS in leading the response, say, between 87 and 95? So I'm going to take some of you back. Some of you may not have been born by then, but let me take you back to then when we first recognized the disease and we realized there was a 10-year interval between infection and disease. So that really had concealed a lot of the early spread. So this was a real challenge, that the disease had spread widely into several communities, even before the media knew about it or physicians had seen cases. And it was quite a wide problem. And so we were playing catch up from the beginning. So that's the first challenge we faced. I'd say catch up. Secondly, the disease created great stigma, discrimination, and denial by countries. Remember, from the outset, there was what Steve calls a topography of blame and accusation. Those who were infected were men who had sex with men, individuals with multiple sexual partners injecting drug users. Its major spread was through sexual intercourse and injecting drug use. Many of you have seen, hopefully, or certainly new patients, that the disfiguration, if you've seen the movie Philadelphia, which is a lot of the way young people get exposed to what AIDS looked like. Tom Hanks did a brilliant job there in portraying an AIDS patient. The Kaposi sarcoma, there was this disfiguration which really frightened people. And then you had, as I mentioned, this 10-year interval. So the disease is, first of all, spreading like we didn't know how far. And secondly, immediately you find stigma, discrimination, and denial. So that's what we faced when we started. And then, of course, I've already mentioned WHO's leadership. So I was in WHO at the time, and before he passed away, I talked at length to Houghton Mahler, who was the Director General at that time, about why WHO essentially did nothing for 5 years. We could say 4 years or 5 years. And he was very frank with me about the fact that WHO just was not comfortable, he felt, taking on a, quote, social disease. And he just didn't feel as an organization, and this was its strength, and also there was the sense, and there are some good quotes about this, that he felt, leadership at WHO felt this was a rich man's disease. It was occurring primarily in rich countries, and they could take care of it. So the third obstacle we had was, not only was it out there and we didn't know how far, not only was there discrimination, but WHO, we didn't act on it for at least 4 or 5 years. And there's a critical moment in the book in 1986 when the representative from Uganda at the World Health Assembly steps up in front of a very hushed audience and tells the world that Uganda has AIDS and we're desperate for help. And this started a cycle of African governments finally starting to admit they had a problem. But it wasn't until the World Health Assembly of 1986. Now, Fakhry had already done some work, but this was the first public outcry in a public forum in the World Health Organization. Fourth problem we had was WHO's structure, the challenge, and our organization. So we can talk about WHO, and I will in a little later, but WHO, the biggest challenge we had was that once we got the program up and running, there was concern about whether WHO had the structure to be able to run a global program, particularly that had an implementation component to it, working in the countries. And what had happened is that when Houghton Mahler, who was the Director General at the time, initially, started the program, he operationally put the program in his office. And that way he was able to get around the regional office structure. And out of his office, this is what had been done in smallpox eradication, and which had worked so effectively. And what had happened was that he took that model and tried to make it work directly to the countries and bypassed the WHO infrastructure, which had operational problems. When Hiroshi Nakajima replaced Mahler as Director General, there was great concern among the donors whether WHO could deliver, particularly in the African region, because our office there was very weak. And I did all I could to assure our donors that the program could operate efficiently, but we could not convince them. So that was the fourth problem. Three other quick ones. There were real conflicting views at the time on the strategic approach to AIDS. Was it a health issue, a biomedical issue? Was it a development issue? Was it a human rights issue? There were these camps that had built up, and I did all I could to shake off the accusation that WHO was only pursuing a medical model. We tried very hard to work with other agencies on the development issues and on the human rights issues following John's resignation, but we could not convince many that we were just not following a medical model. There was also competition among the UN agencies for resources. UNDP, UNICEF, and others all started to want to have programs as well, and that really made the donors very frustrated. And so this was also a problem we couldn't resolve. And then the last challenge we had, so we had AIDS problems, we had WHO problems, we had strategic problems and challenges, and then we had the most serious concern that occurred in 1992 when Hiroshi Nakajima, the Director General, got reelected. This was a very controversial reelection. Jonathan Mann had resigned his post as Director of the Global Program on AIDS in 1990 after only directing the program for 3 years, and then I replaced him. He resigned because of a terrible argument with Hiroshi Nakajima about whether or not AIDS should be handled as a human rights issue. Nakajima really felt it was a biomedical issue and really had exception on John's commitment to human rights. The donors were concerned in that in the 1992 re-election of Nakajima, there had been a real cloud of suspected bribery and financial irregularities. So those are all the challenges we faced and which eventually, unfortunately in some ways, led to the closure of the program. Now, I just want to say clearly, and I don't want to make this doom and gloom, I believe Global Program on AIDS had incredible successes in raising awareness about the pandemic, formulating policy based on evidence. We had no inhibitions about the topics we were covering. We covered a broad range of prevention strategies. We provided support to 120 countries, and many would say that was the greatest achievement. Many of these countries didn't know where to start in mounting an AIDS program. We established for the first time close partnerships with NGOs and people living with AIDS in GPA. We had a very comprehensive research agenda, and Jose Esparza's here, who led the agenda on vaccine development, but there was drug development, diagnostics, epidemiological and social behavioral research. And lastly, and this is detailed in the book, it's not well known, we actually started the dialogue with pharmaceutical companies on making ARVs available to low and middle income countries. That didn't materialize until 5 to 8 years later, but it actually started during GPA's times. So that is the challenges we faced, and I think we had tremendous accomplishments, but by 1993 a decision was made to close down the program, and abruptly. and to start UNAIDS. And so if you can imagine that on December 31st, 1995, the Global Program on AIDS shuts its doors, and on January 1st, UNAIDS opens. That's how abrupt it was. And in the first paragraph of the book, you'll see poor Jose Esparza getting on an airplane trying to find a job, as many other people did in the Global Program on AIDS. So what were some of the challenges? And I'll go briefly. First, for the Global Program on AIDS, if you can imagine 500 people who had been working day and night suddenly are losing their jobs. But I have to tell you, the staff worked as hard as they could right to the end. But on the other hand, they didn't know what their next job was. Some of them did go to UNAIDS or elsewhere in WHO. Some did not. And in the end, there was a very substantial lawsuit taken out against WHO for breach of contract. And I have to say that neither GPA, and I discuss this in the book, we discuss this, or WHO handled that very well. The second challenge that we had in WHO, we had to create the mandate for UNAIDS and the 5 co-sponsoring agencies. That's what the World Health Assembly had decided. And I personally had to present to all 5 governing boards of these 5 other agencies. Many of them were suspicious of me. They were suspicious of WHO. What was WHO really cooking up? But this was not going to be a continuation of the WHO program. So we were faced as WHO Global Program on AIDS, forming UNAIDS, when we in turn were being shut down. And there was also enormous tension at that time, those of you who are students of the Cold War, between the leadership of the Economic Social Council and the UN in New York and the WHO in Geneva as to who would control UNAIDS. This was a critical time where the UN was seeking a very optimistic UN reform movement after the Cold War, and they felt that AIDS could be one area where the UN in New York could take leadership. So we were faced with tensions in creating UNAIDS among the agencies, and we were faced with New York-Geneva tensions. For the countries themselves, the 100 countries that were receiving aid from GPA, that stopped. That stopped because UNAIDS did not have a budget to help countries. So the money that was going from WHO to all these countries, 100,000, 200, 300, 400,000 a year, was no longer available. So the countries really faced a shortage of resources. I don't think they fully understood what UNAIDS was going to do, and I have to feel that this likely cost some lives along the way. For UNAIDS, they had let me just say, it had its own challenges. It had to recruit a director, a staff, and set up a governing and operating structure in 1 year. The selection of Peter Piot as the director of UNAIDS was a highly politicized process, which is described in the book. He was finally appointed by Secretary General Boutros Boutros-Ghali in 1994, and he had to establish the program in the face of tensions between UN agencies, the expanding pandemic, and the plan to shut down GPA. But that wasn't the only thing that UNAIDS faced. They faced 2 other issues. One was the behavior of the UN agencies themselves. I sat in a room with Boutros-Ghali and the 6 UN agency heads, and every one of them strongly agreed to create UNAIDS. But that's not what happened. As soon as UNAIDS was created, WHO went home. When the GPA was shut down, there were enormous tensions between UNAIDS and WHO. Some of the regional directors even wanted the program to fail. But even more importantly, UNDP refused to shut down its program for 2 years. And so there was a war literally between UNDP and UNAIDS. Even though WHO had shut down its program, UNDP refused to shut down. It eventually did. And then there was the behavior of the donor community. So imagine the donors had decided to shut down the Global Program on AIDS for the reasons I mentioned. And what did they do to UNAIDS? They cut their budgets, the budget in half. So they didn't provide the resources that had been expected. They actually cut their funding wanted to cut their funding, I should say, by as much as 50%. And they also did not hold the UN agencies accountable for their agreement to form UNAIDS. They allowed this bad behavior among the UN agencies to continue. Some even felt that the donors' inaction in this regard maybe really that their goal had only been to shut down GPA and after that, their responsibility ended. Now, UNAIDS found its role in the global response with the discovery of ARVs, in bringing the price of drugs down, advocating for access. It took the lead in providing country, regional, and global data related to the pandemic. And those of you who have read Peter Piot's book, No Time to Lose, he talks about this in great detail. We don't rehash this. We talk a little bit in the book about it, but not as much as his book does. Then, of course, the Global Fund and PEPFAR come about in 2002 and 2003, which had far more resources than UNAIDS. And that's reshaped, in a way, what UNAIDS has done, but it continues to have an important advocacy role, and of course was responsible for setting and monitoring the 90-90-90 targets. So that's, Sarah, that's what you asked. Now I'll just finish with the takeaways. And Steve's going to help me with that. I'm just going to quickly mention 4 takeaways. First, I think it's obvious that mounting a global response to a pandemic, especially against a new and presumed fatal disease, is a complex process. It takes an enormous amount of time to establish a program on a global scale, recruit staff, raise resources, develop strategies, and maintain momentum. And shutting down such a program, no matter its perceived shortcomings, you really need to be done with great caution and careful assessment of the consequences. The appeal in the book is that donors should not be impulsive when launching and supporting new programs and impatient when demanding results, and resist shifting strategies to pursue short-term solutions to complex problems. So that's the first lesson that you can take away from the book. Secondly is, I would call, the lesson of accountability. Particularly in the face of pandemic, donors, international organizations, and the like need to live up to their commitments. There are many examples in the book of this, the most obvious one I've already mentioned being the failure of the UN organizations to live up their commitment to UNAIDS, which wreaked havoc, as I've already mentioned. But even today, this lack of accountability and transparency is an issue in the global fight against AIDS, Sarah and I were talking about earlier this morning. Thirdly, are the strategies for confronting pandemics. There's very rarely a magic bullet immediately available for a pandemic, and if there is, great, but when there isn't an obvious, very effective vaccine, we need to look at a comprehensive response. This is certainly the case in AIDS. We have to remember that prevention is a slow process, and when you have a disease that evokes panic and discrimination, like AIDS did, it makes it even more complex. But this argument about public health, medical model, development model, human rights model, all these play a role in dealing with complex pandemics. And these kind of arguments really are not in the best interest of a response. And the importance of civil society and the private sector cannot be underestimated. GPA was very good with civil society, did not involve enough the private sector, but certainly UNAIDS certainly did a wonderful job in dealing with the private sector. And then the fourth lesson, and then I'll turn it over to Steve, is what does this story tell us about WHO? Well, I think one cannot deny that losing the global program on AIDS was a great loss of prestige for WHO. And I'm just going to read here more or less what we say in the book. Faced with a declining contribution to its budget, hampered by an archaic regional structure, and crowded by an ever-growing field of global health actors, WHO has struggled greatly for the past 2 decades to locate its place in the field of global health governance. It's certainly not the organization with the reputation and prestige that it had when I first joined in 1978. And its failure to respond to Ebola in 2014, it certainly did not surprise me. There have been many recommendations for improving WHO, and as I've mentioned already, that certainly Steve and I feel that we hope that WHO and the member states now, under the new leadership, find the will and the courage to make the reforms that need to be made. It may require a change in structure and mode of operations, but they've got to be made. We need WHO to be our leader in global health. Steve, I've talked too much. Over to you.
That's all right. He's listed several that we come up with. There are ones that struck me that I think HIV really kind of brought to the fore. One of them is just that diseases reveal a lot about us as people and in society. So the idea that vulnerabilities matter. I think HIV really made people aware of the role of human rights, the role of the vulnerability of women, and then designing interventions that actually take those things into consideration is kind of one of the huge lessons that we learned. And so going forward, making sure that we incorporate those type of things. And also that health systems matter. There were plenty of countries that were, terribly affected by HIV. And we've obviously found this with Ebola and other, and there's no infrastructure, health system infrastructure in those countries. So to go in and to design an intervention without thinking about the implications for building or rebuilding or leaving a sustainable health system, those are important things so that when those dollars go away, does that mean the health infrastructure collapses in a country because a donor nation has just been focusing on one disease rather than the system within which that disease is cared for. One of the other things we found in this is, the allies can be found in unique places. There's some places where there wasn't a health system, and Mike or GPA or whomever would really find with the religious community or NGOs, business communities often were ones who, the health of the population mattered and were hurting them financially. And so those are the folks you wanted to ally with. And those were kind of unique things that up until that time, global health hadn't always taken into consideration. And then I think one of the last important lessons, or one of the last ones is, that progress isn't permanent. That the reality is we can make advances. If we don't have a cure, obviously, then we have to be vigilant. And cutting budgets has implications. On the science front, evidence matters. I am a big proponent of incorporating health and human rights, but one of the challenges that we talk about in this book is the real struggle of a focus for operationalizing frameworks to make sure that you have public health outcomes that you can measure. Therefore, you can see that you're actually doing something. And those are very, very tricky to do. It makes rhetorical sense. It makes social justice sense. But how do we operationalize that in ways that on the ground make an impact in people's lives? And scalability is really, really hard. You'll have a small intervention or a small research project that works in one area of the community, but you try and take it national and you realize, now we've regressed to the mean and this actually doesn't, but we've published these things and people say this is the way to go and the health community shifts because this looks like a promising practice and then become disappointed. And I think one of the things we really try and focus on is we can become very monophonic. That old proverb, he who is good with a hammer thinks everything is a nail. And oftentimes one of the debates between the UN agencies was my way's right and your way's wrong. Instead of having a more polyphonic approach that says my way is really good in this context and your way is really good in your context, and how do we work together to make the sum greater than the individual parts. I think for me as a historian too, personalities matter, right? The recognition that no system is above the individuals who are at the top of it. And so one of the things we talk about is the way fiefdoms often would evolve. People are very afraid of their job going away if funding gets cut or if this other organization kind of rises to the top. And the problem is that has implications for the way we deliver healthcare. And I'm one of the first to admit I've got an ego. And the problem is if my department is not getting as much funding as your department, then I got to figure out how I can get more funding. And the problem is there are lives on the line, obviously, in global health. That's a real challenge, is how do we build systems that allow for the fact that sometimes people can be really petty, but we don't want those pettinesses to drive the outcomes for millions of people. So I'll just leave that there and maybe we open it for discussion.
Okay,
Great.
we answered your 5 questions.
Thank you so much. Maybe just one follow-up question before we open it up to the audience. Financing and political will, this has obviously been a big theme of our discussion so far today. Steve, you talked about progress isn't permanent, and as I mentioned at the outset, we've seen a reduction in funding for HIV globally over the last couple of years, flatlining for the US budget, and now a proposed decrease of $1.1 billion. What do you think are the ways that we can try to regenerate the political will and that focus that's necessary to make the argument for sustainable financing going forward?
Well, I can start. I'm sure Steve will add. I think first, we've got a broader problem than AIDS when it comes to global health right now, and that's we're in Washington where no one knows this more than you, and that's the rising trends in populism in the US and in Europe, the anti-global rage that's out there, and the need to remind everyone why global health is important. Of course, AIDS is part of global health. So I think we need to start with that and reminding people. I was recently part of a National Academy report on global health in the United States government, where we try there to talk about the importance of global health for security, for economic development, for saving lives, for humanitarian reasons. So I think the first thing is to recognize the need to remind political leaders around the world of the importance of health in the various aspects I've mentioned. I think with regard to AIDS, we have made great progress. As much progress as in many other diseases. 50% of people on treatment, I don't know how many, if you look at tuberculosis, we're in much worse shape. So we need to recognize our achievements, and we don't want to be, as you say, complacent. There are pockets, as you mentioned in your introduction, in Southern Africa, where certainly the pandemic could rapidly spread, particularly in young people. That's really frightening. We don't want to be complacent. But on the other hand, we need to recognize that in today's world, there are a lot of other health problems that deserve priority. And so how do we maintain and support those as well as what we want to achieve in AIDS? The AIDS advocates obviously want, and that's fine with me, to get everyone on treatment. Well, we ought to get everyone on treatment for all diseases. And so the question then becomes, how do we advocate for AIDS and at the same time not appear to be exceptional? And I think here, getting serious, for example, about health systems for once is a good idea. I think we still, though, need to remember the devastation that AIDS can cause and be sure we have the resources to do the critical priority actions that are needed. We can debate what those are, but I think most people feel that treatment is the priority today. A vaccine would be enormously helpful in meeting the 90-90-90 targets. But I think the AIDS advocates have a challenge of advocating for AIDS and the resources and fighting the complacency that can exist by being successful. But on the other hand, being aware of the other priorities and trying to work more together. This is and I know that's easy to say, but I do think that's the world we're in today. There is a discussions underway. Some of you may know this about an ending AIDS coalition and having AIDS no longer be a quote epidemic or pandemic. And I think that's a great idea. We should support it, but it hopefully cannot or should not divert resources from all the other priorities that exist today in global health.
You know, I think too, one of the things we talk about in the book, when UNAIDS was established, one of the ways people talked about was about efficiency, that UNAIDS was going to be able to run leaner and meaner than WHO had done. And I think it's a noble thing to strive for efficiency. But efficiency sometimes can be a label under which we smuggle in cutting budgets. And I think if we're going to move towards efficiency, it needs to be smart efficiency. In the case of HIV, and we talk about this in the book, Gary Slutkin obviously had done a whole bunch of work. The folks in Africa saw amazing success in Uganda in stalling its epidemic and really starting to turn the numbers. And I think Slutkin would argue that what ended up happening was when the money went away for the other countries, that they were unable to see the same type of progress that Uganda had. And so what the 1990s and early 2000s in Africa looked like under the name of efficiency and streamlining was actually millions of lives, damaged or lost. And so if we are taking money away, it needs to be done fully acknowledging that there are consequences in real lives to taking money away, which doesn't mean that you don't shrink budgets or divert funds in other ways, but that you do it in a way that is smart and calculated. It may be a step down rather than just saying we're slashing the budget here. And I think the other thing is also if you're shifting costs from one to another, that you're thinking about the health system so that if you're cutting costs in HIV, that where you're investing it also can benefit HIV, right? So I think that's why when we talk about health systems, the idea of just cutting programs for their own sake, we learned, at least in the story of GPA, that is catastrophic. And so I think holding those things up. And the other thing, even with flatlining budgets, Mike experienced a flatlining budget, but the problem is pandemics don't flatline, or they don't necessarily flatline. And so one of the things, Jonathan Mann raised a whole lot of money, and he had a huge buffer that he could shift around to new countries as the epidemic spread. And then eventually the donor nations held the money at the same amount. Mike then saw the number of countries asking for help filled all the way up to hit that amount of money. So holding a budget steady may actually end up meaning that you're trying to do more with less. And so I think being honest about the scope of pandemic, and the reality is this treatment is costly. It may be that there are less people affected, but if we're going to focus on treatment, now we're making a lifelong commitment to people. And so thinking about how we do that sustainably, both for the donors, but also for those have to be part of the discussion, and not just the national budget, even though I recognize those are huge political.
I think, Sarah, that just to pick up briefly on that last point of Steve's, in the National Academy of Medicine Committee, we discussed this point quite at length. PEPFAR has done a marvelous job of no question, as has the Global Fund. And a lot of that, the Global Fund is a lot of U.S. support for treatment. But it's an important question to ask, which is how long can we expect PEPFAR and the Global Fund to maintain the treatment of millions of people? And will we be able to get countries themselves to raise the resources and make the commitment to their healthcare systems to eventually pick up that cost? Right now, my understanding is South Africa and Botswana have done a pretty good job of that, but there needs to be a lot more focus on that. I mean, we've talked in our work. We obviously talked with PEPFAR about this, but it's really got to become more of a commitment to deal with Steve's issue, because we can't shut off the funding for treatment. But on the other hand, one cannot expect the U.S. Congress to continue to support at $6 or $7 billion a year this treatment cost. So something has to be worked out here, and that's more a domestic issue in some ways, but I think it has to be frankly discussed. And now that PEPFAR is focusing on specific countries, maybe that will be more on specific countries. Maybe that will be part of that effort. Hopefully it will be.
Great, thank you very much. Before we open up to audience Q&A, let me turn to Steve Morrison, our Director of the Global Health Policy Center and Senior Vice President here at CSIS, to offer a couple of words. And while the mic is coming to Steve, let me just note that Dr. Merson and Dr. Inrig will be at a table right outside the doors immediately following if anyone wants to have their book signed.
Thank you. And congratulations on this book, Mike and Steve. I've been hearing about this book for a long time.
I know you have, I know.
And I think you've proved the value of patience and determination and taking this approach. And it's wonderful to see that. I want to offer first a note of thanks from CSIS to you, Mike, in particular, for the many contributions you've made to us. When we were launching the CSIS task force on HIV/AIDS back in the end of 2001, and enlisted John Kerry and Bill Frist to co-chair that and pull together a number of folks. One of the first people we called on to help us was Mike, and you were very responsive and very supportive of that, and it took many, many forms in terms of speaking at fora up on the Hill, going on trips with us, delegations to India and elsewhere, doing activities in the Research Triangle as you were launching the regional group there. And as you've worked your way through the recent National Academy of Medicine, working closely with us on profiling those results, working together on the Fogarty board. And it's just been so valuable to us, and you've been so generous, and I just feel like I have to make that point here, and thank you so much. And I'd include in that launching this consortium of universities of global health, which was a very important thing, which you may recall we did the initial scoping here in this building around that at your urging. that we needed something like this. So thank you. The question I wanted to ask is, are we being too polite? We're in a moment here in time. There have been quiet steady regression of resources over several years. This isn't just a new phenomenon, but it's a phenomenon that poses the potential for a more radical regression. And the adjustments that have been made in the last year are of another scale than what we've had before. And this is a community that grew accustomed to a marvelous 15-year trajectory of growth and relative stability and predictability of resources. And the achievements that we can point to today built on that remarkable consistency and continuity of leadership and commitment and funding and predictability. Even if it flattened, and even if it was still something that people had confidence, the bipartisan coalition was holding, presidential leadership was holding, all of the various partners were staying inside. But that's changing now. Now we're at a different moment where the potential for a radical regression is real, and different scenarios are possible. It's not guaranteed. We've had some very good gains this year in terms of congressional intervention. The mobilization of the community and its various constituent parts has been very impressive. But to get back to my question, are we being too polite? I mean, this is a movement. The HIV movement was in its roots and in its bones confrontational. It was one that didn't shy away from being confrontational. In this particular moment, confrontation can carry very high costs. But it's also been a period of relative politeness, I think, in the way that these changes have been met, and yet it contradicts a cultural history of the HIV/AIDS sort of social movement. So I wanted to put that question out and see what you had to say. Thank you. And thanks, Mike, for all of your great work.
So why don't I let you answer that one, and then we'll take a few additional ones.
Well, I'm not known for being polite, but all the time. But I think, Steve, first of all, the movements have their moment, right? So I think AIDS very much, as you said, Sarah, was at the birth of global health in many ways. I actually gave a talk on this to students this week at Duke, and I put a talk together, which I had not done before, on that topic. And it's really quite striking, if you look at many things that happened in global health, how much it parallels what happened with AIDS in 5 or 6 different ways. So now we don't have that leverage. I don't think AIDS can be that leverage, Steve. So I mentioned this earlier. We obviously, I don't think as you say, we've not yet taken the hit we could take. And we've managed to do pretty well. But there are other issues that deserve more attention today as well. Just look at the environment and climate change. I mean, look at the enormous impact that's having on the world's health and all the problems it's faced in trying to get the resources it needs. So I don't have a simple answer for this, but I do think that, and I mentioned this earlier, that the global health community has got to think, we've been spoiled a little bit, and we have got to mobilize around the reasons why global health is so important. It's one of the reasons I've had an opportunity to take that National Academy report and speak in numerous places, because I think it's a leverage at least to get the discussion going. But you're right, I don't think yet that the threat has reached enough people to respond the way you're saying. I'd like to think the best hope we have is our students, because I've been worried that there might be a drop-off in students in our universities going into global health. In fact, that certainly on our own experience, that's not the case. We started a new college major, and we have 300 students in that major after 3 years in global health. But this could happen so we need, Steve, and maybe you and I talked a little bit about this. Maybe CSIS, because you were very kind to me. I just want to say that you have been in all the think tanks in Washington or policy organizations, no one has led global health and AIDS better than you have. And so maybe we need a kind of think tank or some group getting together to really think about how to take this on. I mean, you've given this thought, I'm sure, Steve, and I know we have this one coalition in Washington. I'm sorry, I forget her name, but she spoke at the dinner you organized. Liz. USGLC, Global Leadership Coalition. And I do think it might be time to do what we did around AIDS, which is, I don't know, but to get some people together to think about what the leverage points are, what the mobilization should be to make this happen. I don't think it's going to happen on its own. People are afraid. There are a price one pays for bad behavior in this town. So I think that the threat is real, and the National Academy report was one effort, but in and of itself, it's insufficient. So I think this is, the only thing I can think of right here is that, look, mobilization has worked not just in AIDS, but in breast cancer, in neglected tropical diseases, in tobacco control, there's an accelerating access initiative that came out of the recent World Economic Forum on NCD drugs. I mean, we know that we can mobilize. The question is what is the leverage points and how do we do it? But I don't, it's not really an adequate answer in some ways, but I'm all for being part of such a movement and not being nice. I don't know whether ACT UP signs will work, but I think we need to come up with something. If we stand still, we're going to pay a price.
Well, can I say something impolite about politeness? So one of the things we talk about in the book...
Yeah, go ahead.
Is there's a moment where domestically HIV activists got a lot of what they wanted. And Mike is at GPA at that moment. And he found that at that moment, a lot of those individuals became quiet about global AIDS.
It's in the book. Some of them may not like what we say.
And we're all for, I've written on HIV domestically and the discovery of AZT and ACT UP's efforts in North Carolina. And so I'm all for those kinds of things. But when people get what they want, oftentimes they're self-interest. And now there were several activists who didn't. And so Mike began to partner with them. So what I would say is this, is if you're going to be impolite, make sure you're impolite not just for the things you want, but for the things that global health needs. Because if AIDS is going to become impolite, it needs to be impolite for global health and not just for AIDS.
That was my point.
So that would be one thing I'd say. The second is, and this is maybe anathema, you need conservatives. So my first book is about the role of C. Everett Koop in the AIDS movement. Having a conservative who can voice that this is damn important and we need to do something about it. And in the book, we talk about, not Strom Thurmond, but Jesse Helms, and how how folks got Jesse Helms to care about the fact that AIDS was killing babies. That people, evangelicals who are giving to World Vision, who are getting letters back saying, my parents died. And they're sponsoring these orphans whose parents have died of AIDS. That's how you got PEPFAR, is you had conservatives who said, this matters to us too. And it seems to me that if the dialogue is about just buttressing government in ways that conservatives don't necessarily care about, then that is going to be a non-starter in terms of you pushing the ball forward. And I don't necessarily know how to do that, but thinking through the implications of global health on the things that conservatives care about as much as liberals care about is going to be a way, it seems to me, that you're going to be able to sustain some things. So I think if you're going to raise hell, make sure you raise hell with the right kinds of people. I don't mean that in an exclusionary way, but make sure you have a broad table of people who give a damn about this. And I've now cussed twice, so my mother won't like that.
And you've been very good at that, Steve.
Yeah.
Okay, let's open it for Q&A and take 2 or 3 questions. Let's start here with Jeff.
Sure.
Go ahead, and we'll get the mic over to you in a minute.
Thanks. Hi, I'm Jeff Sturcho with Rabin Martin, and this has been fascinating. I can't wait to read the whole book because your book ends at just the point where I started getting involved when I was at Merck in helping to deal with the AIDS epidemic in the mid-90s. So I'll look forward to reading it. But the thing that most surprised me about what the two of you said this morning, though, was your comment recounting Halfdan Mahler telling you why he didn't do more about HIV and AIDS in the early years of the epidemic. And if I remember what you said, he said that it was a rich person's disease and it was a social disease. And the reason that's shocking to me is that you would think that the head of the WHO would have been more interested in what the evidence was for the public health impact of this disease, rather than being concerned about particular caricatures of what was happening. So I wonder if you could just muse a little bit about what it was like inside WHO at that time as knowledge about HIV was becoming, was rapidly coming out as you began to learn more about it wasn't just the 4 H's, Haitians, homosexuals, right. Heroin users, and I forgot the fourth, and hemophiliacs, of course. But it was a disease that was global in scope, and it was, shortly afterward, it was clear that it was affecting Africans as well, and Projet SIDA was starting at that time. So I'm just curious about what the environment was like inside the house
Right.
Of the premier public health institution in the world that was taking sides on whether it was a development disease or a human rights issue or a biomedical issue, when of course it was all of those. I just found that surprising.
So a couple of things in that respect. So remember, Mahler came in the 70s and stayed till 88. So he was he finished his term in 88. But the AIDS is, we get first cases in 81. So we're talking in a period of 81 to 84, let's say. And remember, at that time, smallpox has just been eradicated. So WHO is feeling quite good about itself and feeling quite, that is a disease that has been eradicated. It's a disease that is transmitted. There's a vaccine for it. And historically, WHO was mostly physicians, and it was mostly thinking about infectious diseases because that was the main causes, but the more traditional infectious diseases. Here you had a sexually transmitted disease. That's what he meant by social. Mahler himself was a missionary, Danish missionary family, had lived in China and India, had worked in tuberculosis. I think this was, for the leadership of WHO, having to deal with an epidemic, although it was infectious, it was sexually transmitted. And of course through injecting drug use, although that wasn't the predominant thinking at the time, although it was happening. But the people getting it through hemophilia, they were innocent victims, and mother-child transmission were so-called innocent victims. And so it was WHO think at that time is very traditional infectious disease, eradicating smallpox, vaccinations. There was the beginning of the EPI program, the expanded program on immunization. So here we're dealing with a sexually transmitted disease. And all the reports coming out, if you go back and read the press in that period, are from the Western countries, from the North. You don't hear about AIDS in Africa. That's why I deliberately mentioned the room of the World Health Assembly was absolutely silent when this Sam Macquarie from Uganda stands up. It was a shock that here is we knew that we knew it was happening, but it wasn't being reported, it wasn't being said. So he was also the second thing he was dealing with was this, the countries wouldn't talk about it. There was no discussion in the building among the staff. I remember I was running the diarrhea program and I kept asking Fakhri, what are we doing about AIDS? What are we doing about AIDS? But it wasn't coming from the countries themselves. And so Mahler was a little bit hamstrung by that, because if the countries don't want, if particularly African countries at the time didn't want to talk about it, what could WHO do? It would be in a way not being very nice, as Steve is saying. Maybe we should have been not very nice, We should have insisted that they deal with it. But those are the things so the two things I would say are the fact that it was a social, sexually transmitted disease, and the countries are not talking about it. And that's why this turnaround occurs. Fakhri Assad, as Steve and I Steve in particular, really wants to write a separate piece on Fakhri Assad. Fakhri Assad was a virologist. Jose knew him very well, who was a classical virologist, knew some epidemiology, and was the only one in WHO. He was director of the Division of Communicable Disease, trying to get something done. And what he set up was some work on laboratory surveillance, diagnostic tests. What he knew, tried to get some collaborating centers appointed, but there was no way he was going to work with the African countries directly. He traveled to India, and in fact, very tragically, he died of acute, I guess, leukemia of some kind.
Yeah.
Right around the time Mahler is making this famous speech in the UN, which we feature in the book, in November of 1996, where he says, "I messed up." Mahler makes a very dramatic speech in the United Nations in New York in November of 96. Man has already been hired, right?
86.
86. Man has just been hired for about 5 months. Fakhri can't go to New York because he's dying. And on the airplane, on the Swiss airplane, a man and Mahler scratch out a budget that they're going to announce is needed to deal with AIDS by the year 1991. They scratched out a budget for the program on the back of an envelope. I think they asked for $1.5 billion, which was unbelievable. Who would ever ask at that time? I know now it's nothing, but $1.5 billion. So it was, he really flipped Mahler. But it was only under the pressure that he had to do it, he told me, because the African countries had finally come out. So you had that kind of problems to deal with. Now, could he be criticized? Sure. He could be, but, and that we lost another, we lost the time between infection and disease, because we were seeing disease in 1981. And then we lost another 5 years because we didn't do much. So we started so late in dealing with this pandemic.
And we try and go through that in very great detail in the book about how Fakhri Assad becomes convinced that HIV is a big deal. Because remember, Project CETA didn't really get going until 83 and 84. So we did not have a lot of global evidence that HIV was as bad as it was and heterosexually transmitted until 84 and 85. And so that's when all of a sudden it really starts to become, and so we talk about how Assad becomes convinced and then how he had to convince Mahler, and that's just kind of a transition. And at the same time, I want to defend the Africans. By 1983, as we start to see this is probably a virus, then people in the press are saying it's of African origin. And then, of course, racism and colonialism comes in. Because then it's like, well, how did we get this from Africa? Well, Africans have sex with monkeys. And so in Africa, there's a lot of countries, newly independent, that are saying, you're blaming us again. And you're saying this is our fault. And so acknowledging it within the confines of their country becomes, something about kind of the entire African freedom movement to say, here's another, because it was so politicized and racialized in the sense of what is it about, in the same way that I think men who have sex with men in the United States say, what is it about gay men that's giving us this disease? What is it about Africans that's giving us this disease? And I think that was a very difficult thing for African leaders then to stand up and say, yeah, we have this disease in our country. And I think that's why when we talk about vulnerabilities in the social context of disease, recognizing that there's all this discourse around disease that assigns blame to people. And therefore, if you're expecting them in the midst of this blame to acknowledge, yes, I'm at risk and I need help, that's a very, very difficult thing to do when.
And of course, this replays out in South Africa, 10, 15 years later. Think about that. I mean, look how long it took Mandela. We talk about that in the book, very frankly. Look how long it took Mandela to even mention the word AIDS, for the same reasons that Steve was mentioning. We discussed this. Because it replays out again, literally 10, 15 years later in South Africa, which winds up having probably the worst epidemic.
Okay, let's take 2 or 3 questions, and then we'll answer those when we're done. Over here.
Emily Conran with World Vision, and I wanted to ask a question about advocacy messaging, and really thinking about some of the messages that have come to the fore, especially in the advocacy space in the past few years, the end of AIDS and AIDS-free generation. And then I'm struck by the contrast with, we've just now surpassed 50% of people on treatment. And I understand the tremendous accomplishment that is, and decades of progress that took to get to that point, but my personal concern is that sometimes our messaging doesn't match up with the reality, and that perhaps in an effort to be inspiring and to mobilize people, we've maybe instilled a false sense of security and even complacency. So with your historical perspective and having been in this fight for so long, I'd love to hear thoughts from both of you about what some of the more helpful advocacy messages might be right now, particularly at this political moment, and then moving forward as we think about what we need to accomplish over the next decades.
Okay, let's take one or two more here. Over here.
My name is Michael Azufo. I work for the World Bank, and some of the issues that Michael raised take me back to triple CD, which probably some of you are too young to know about. But this was a US program for combating childhood diseases in Africa. I went to Guinea in 1987, and I was looking at the healthcare system, and I went to a district clinic. And after I talked to the community and the staff, an old man pulled me to the side and took me to a little office in which he had this old printing.
Yeah, the photocopier kind of thing, the carbon copy. Yeah.
And produced his report on childhood diseases for the last year, last 3 years actually. And he said, "Are you coming to start triple CD again?" You see, we had measles up here, and it came down in 3 years. Then triple CD ended up, and we're back to where we are. I think it brings back the question of systems development. I wonder what would have happened if Jonathan Mann had been stayed alive, whether we could have told a different story from this. The AIDS program, I've worked with all the donors, and the greatest problem that has been in the field is donor arrogance and donor competition. Even when we thought we were now finding solutions, I go to the field, and the country programs are managed by UNDP, which answers to the major donors, and you still have a program that is being implemented by GTZ. And I asked the GTZ guy, I said, "Do you think you can complain about UNDP? Or UNDP, can you complain about GTZ when the Germans are sitting up there to provide more money?" So there's a lot of mess up. In Mozambique, I saw the same problem, USAID fighting with Sant'Egidio about a lab, the use of a lab for tests. So I think we have not really been very nice to ourselves or honest to ourselves. The perception of AIDS as a Western country generated disease perhaps did not hit the Western people as much as somebody like myself, who is African. Because for 3 years I tried to get Cote d'Ivoire to include one sentence in the president's speech at the end of the year about HIV/AIDS. The minister was a glorious professor in medicine. And he told me that, how can you, an African intellectual, buy into this nonsense? So I think we have not, in your analysis, we haven't seen the other side. The African, a greater analysis of the African picture. But I lived through it.
Thank you very much. One more question here in the front.
Jose,
and-
Two more.
got a call on Jose.
So I'm Jose Esparza, now I'm retired. I enjoy your presentations and brought me memories of the time that I spent in Geneva in GPA and UNAIDS, and obviously we were very proud with what we're doing. But now with time, I think that we actually failed, and allow me to be provocative. I mean, we are implementing Plan B. Plan B is to provide antiretroviral treatment to people who become infected. Plan A is to prevent infections. And we have failed globally, although we are very happy every time that we see that the epidemic is plateauing, but it's not really being under control. But even in the US, we have seen basically around the same number of new HIV infections for the last 30 years. I mean, from 180,000 in 81, 82, down to about 50, and then maybe 40, 30, but that's what it is. What has changed is the demography. Now today, people who are becoming infected in the US are African American, Hispanics, rural, less educated, etc. So for me, this is an indication that even in this country, we have failed to bring the HIV epidemic under control. And we were talking about money, financial resources. I'm not sure, I mean, I tried to calculate how much the world is investing in the response to the HIV pandemic. My estimates, and I have to say, I ask everybody, and I don't have a good answer, but it's about $80 billion a year. And this is because we have to, as Mike said, we have to provide antiretroviral to a lot of people. So my question to Stephen and to Mike is, history is very important, not only to understand the past, but also to inform the future. And how this book can guide all of us to actually to better plan what we're going to do in the next 20 years in the response to the HIV/AIDS epidemic.
Thank you. Okay, let's pause there and go ahead and answer those.
Okay. Steve, you please chime in. Well, let me just quickly go back. I think, of course, Jose, we're in a tough position now because of what's happened with treatment. And, PEPFAR was basically a treatment program. And many people were dying, and it came about, this history when the religious movement and President Bush. And I mean, I'm not being critical, but it is a treatment. It has been primarily treatment. And that we had something that could save lives. And we didn't have a vaccine yet or a real bullet for prevention. So I think we are where we are. And now that the treatment, as you mentioned, Sarah, we now know from 2 studies that if you are, fully treated and are suppressed, you don't transmit. So treatment really is now effectively become prevention. Assuming you can take these drugs, you don't get resistance, you don't get side effects, et cetera, and that's a lot of ifs. So I don't disagree at all with you that in the end we need to figure out how to prevent infection. What we need are somehow the virologists. I mean, I was on a call last week where Tony Fauci is talking about at best a 50-60% effective vaccine. And and if that was the case, better than I'm just telling you what he said, that's not really going to be enough on its own. Now maybe combined with treatment, it would be enough. But I don't disagree with you at all. I think we have failed in prevention. I don't think there's any question about that, except to the extent that drugs, treatment does, if you lower your viral load, prevents you from transmitting. It doesn't mean you're not infected. So I don't disagree with you, and I wish you would get out of retirement and go back and develop the vaccine that we need.
Can I say one thing on that too? And this is not meant to criticize your statement, but one of the things too is that we misunderstand the disease or our epidemic. So in the United States, African Americans have disproportionately been affected by HIV from the very beginning. But our public health efforts targeted middle-class white gay men really well. So we have flatlined in part because the affected population that was affected from the very beginning, so the disproportionately affected population, we just have done a really lousy job at that. So part of the failure is that our public health prevention effort has laudably affected people that it's improved their lives. But there's all sorts of communities. I did a study, my first book, on HIV in North Carolina, and we would take health education stuff made for white guys in New York City and slap black people on the front of them and then pass them out in North Carolina. That's unfair to North Carolina. They've done a good job. But I mean, early on, that was some of the stuff that we did. And the point is that some of our failure is that we still have not learned to know the epidemic that we have. And that's true in multiple countries around the world. One of the reasons we're failing is we have sometimes a cookie cutter mentality rather than one that is designed to address the disease on the ground in a way that's effective for that population. Anyway.
So your comments, let me say, I've thought long and hard if Jonathan Mann hadn't resigned, certainly I would have had a different life. So I detail in the book, we detail in the book that his resignation was incredibly profound on what it meant to the course of the pandemic. It's probably one of the most significant setbacks we had. It wasn't obviously the only one, but a real setback and a tragedy that he resigned. So I just want to echo what you're saying. I think there's another what-if irony. So the Global Program on AIDS, Steve and I have discussed this many times, the Global Program on AIDS shuts down at the end of 1995. In 1996, we announced that we have antiretroviral therapy. And by 1998, and certainly by 2000, we have triple therapy that's coming down in price. Imagine if the Global Program on AIDS had not shut down. We would have really needed WHO. I mean, it would have been primarily getting these drugs out and getting the price down. So if you want another irony, it's that the program shuts down just before we get the breakthrough in treatment. So just another irony in the history of the pandemic to think about. We can't go back and change anything, but it's sort of like, what if Jonathan Mann hadn't resigned? Well, what if GPA had stayed around a few more years? Maybe that would have made a big difference also, because we had 500 people that could have really worked quickly on treatment.
And your question about whether or not what we would want to do to have Africans own this, the answer is we don't want to do anything, because white people in the United States have been telling people in Africa what to do for a long time. And I think probably we'd ask you is, what do you think Africans can do to, and I think that there have been strong movements. We talk about, obviously, several of the civil society groups that kind of raise awareness. And I think that's where the hope is that people in Africa recognizing and being able to, to move through some of the stuff and really make it a movement that they care about on their own, because I certainly have no ground on which to stand.
Right, and we do talk about the denial in Africa in the book. We didn't say too much about that today. You're certainly right. That's why I mentioned the Uganda breakthrough. I mean, whatever we thought of Museveni, that Uganda did have courage that no one else had at the time, and we need to recognize that. You make a point about donor behavior. If there's any group that needs to read this book, it's the donor community. Because if there is misbehavior here, it certainly is in the donors. And unfortunately, we could continue to talk about this. But the donor community is fickle. There's a point in the book, Jim Sherry makes the point, that every 7 years the donors need to do something different. Now, I don't know if that's true. But there is this feeling by the donor community sometimes that they get impatient, new people get in new jobs, and they have to come up with a new solution. I don't know if that's true or not, but I think your point about the donor behavior, I hope they think about if anything, they can learn from this. Now, your question about advocacy is tough. I will show you a headline from 1996. 20 years ago, the Newsweek cover has a headline, "The End of AIDS," with a white pill. This is 1996. So your concern has been going on for 20 years, okay? And why politicians and the media want to talk about that is obvious, but it sells and it helps politicians be positive. I was very nervous when the previous administration in this country talked about the end of AIDS. I didn't know why they were doing that, but I, on the other hand, did know why they were doing it. I mean, politically it plays well. But I do think right now, more than ever, based on the questions that Steve asked earlier, we need to really think about our messaging more than ever. I'm not a message expert. I've talked to communications people. No one seems, Sarah and I talked about this earlier, no one seems to know for sure how to frame things, the message right now. How do we deal with the threat of complacency? How do we deal with the need to bring global health up, not just AIDS? the way to make people think, yeah, we've made progress in AIDS, but we have a long way to go, but it's not the only game in town. I think that's the kind of creative messaging we need more than ever now. So I don't personally have an answer to this, but I really do think you've raised a very critical question moving forward particularly if we're going to have this coalition that's being formed to so-called end the AIDS pandemic. They have really got to think what that message is going to be. What does it mean to end the AIDS pandemic? I mean, even that alone, if we went around this room, I think we'd get 50 different answers.
And we mentioned Jonathan Mann. Jonathan Mann really struggled with this. We talk about it in the book. He was just a consummate communicator and was able just to rouse all sorts of people. But he struggled with apathy, not his own apathy, but other people's apathy all the time. He talks about it right from the very get-go. And eventually what he does once he leaves GPA from Harvard is really, he decides to go puff the numbers, make them big. But I don't know, he found that kind of diminishing returns on that, because ultimately those huge numbers, number one, don't always bear out when you start to measure things, so you lose credibility, and number two, people stop listening when you're talking numbers at a scale that they can't conceive. And so sometimes it's telling stories and being honest about both the progress and the steps that we still have to go.
We are now at time. Thank you so much for joining us today. If you're interested in having your book signed, Dr. Merson and Dr. Inrig will be at the table behind us. And thank you to you both for coming and sharing your book. And
thank you for having us.
Thank you very much for having us.
Thank you very much.
Great, thank you.